All right, the next one we want to talk about for neurologic dysfunction is Parkinson's disease. So Parkinson's is sorry, getting ahead of myself. So dusting off the patho with Parkinson's disease, the key thing to remember from when you guys learned about this in patho is that this is a result of dopamine depletion in the brain. So whenever you think Parkinson's, think no dopamine. For our assessment of Parkinson's disease, when we look at recognizing cues, this is really going to be neurologic and specifically central nervous system type symptoms, because the whole etiology of this disease is a loss of neurotransmitter. The way this tends to manifest for patients is what we call EPS, these extrapyramidal side effects or symptoms or side effects. The other key thing that helps us to differentiate Parkinson's from even things like MS is age. Usually people have an onset of Parkinson's disease with advanced age, so like over 50 years old, not in that 20 to 40-year-old range like we have with MS. When we start looking at tying specific symptoms together, it really is tied around recognition of EPS, extrapyramidal symptoms. So things like tardive dyskinesia is a big one. So these are symptoms like the lip smacking that patients may have while they're not speaking, or pill rolling tremors, which are kind of those tremors that patients experience in their hands where it's like they're rolling a pill between their thumb and their finger. Other ones are ecthesia. So this is rigidity in their joints, and we can actually assess this in patients. So if we have them like hold their arm out, doing like isotonic holding their arm out, and we move them through passive range of motion, it's not going to be a smooth range of motion like you're doing on yourself probably right now. Instead, their arm is going to move up towards their shoulder, like if you're bending the elbow through range of motion. What'll happen is their arm will move like the second hand on a clock, and that's the cogwheel movement. It's that move, pause, move, pause, move, pause, move, pause, move, pause kind of motion. That is our cogwheel movements. Next is Pseudo-Parkinsonism. This is where patients have bradykinesia, so very slow, very intentional movements. So when patients are grabbing items, it's going to be it's almost like you're watching a slow motion video of them moving, but it's real time. So it's going to be very slow to grab an object. They may also have akinesia, which is an absence of movement when they're looking to initiate a motion. So this can present as, you see this quite a bit when you're providing care to Parkinson's patients. And when they're about to grab something or about to move towards something, it's like they stare very intensely at what they're going to do next, and then the movement starts. And that pausing where they're kind of staring very intentionally at what they're going to do next, that's that absence of movement when they're really initiating that motion. And then acute dystonia. So this is like lack of muscle tone. We tend to see this in Parkinson's disease most acutely or most pronounced in their facial muscles. So it's almost like they have a blank expression on their face all the time. This can make communication with them really difficult because we're used to looking for those nonverbal cues like head nodding, things like that, that people are understanding what we're telling them. With Parkinson's patients, totally flat. They don't emote anything on their face. They don't give you any kind of passive acknowledgement of communication. It's just like, it's kind of like talking to a human wall. So it can be really challenging for us when we're working with patients who have that symptom. Next, we're looking at prioritizing hypotheses. On the medical side, it sucks because we don't have a diagnostic test for this. Screening is a big part of it. So symptom presentation recognition of EPS is a big part of our screening. So age, EPS equals high suspicion of Parkinson's. As our third piece of evidence that this is Parkinson's on the medical side is response to drug. So this disease is all about depletion of dopamine. So we give levodopa to increase the amount of dopamine in their brain, and their symptoms should get better because we've replaced what we suspect is the deficit. If they respond to drug therapy, that's highly indicative that we've identified the source of the disease. So if levodopa makes their symptoms better, then we can confidently say they have Parkinson's disease. On the nursing side, our prioritization is really about the effect that the disease is having on their body, not about the drop in neurotransmitter. So one of the a couple of the big actual diagnoses that we look at are imbalanced nutrition, less than body requirements. Because of the bradykinesia or akinesia, it can take a long time for patients to eat. We're talking like an hour to eat a meal because their movements are so slow. It's very possible patients can get so fatigued trying to eat that they don't complete meals. So over a period of time, they can be malnourished. This same kind of pattern also bleeds over into their self-care deficit. So because how long it takes for them to perform ADLs, they may not complete them. So that's always something we want to be looking out for, is how to assist these patients. On the risk management side, there's a risk for compromised human dignity as they lose the ability to care for themselves, and also a risk for disturbed personal identity because their body is failing them. An important thing to remember with Parkinson's disease is their body is not working properly, but their brain is still intact. So they're still cognating and have like that internal monologue like a normal person, but they can't move to match what's going on in their brain. So it can be very, very traumatizing for patients. So we talk about generating solutions for Parkinson's. We have that same presentation like we talked about in MS. There's a chronic or a stable phase, and then patients can have exacerbation of the illness. For the chronic stable phase, we're looking to maximize independence. And the big way we want to do this is multidisciplinary. We want to call the friends, and we're talking about all our interdisciplinary team, and we'll talk about those specific roles here in a minute. The other thing on the medical side is levodopa or L-Dopa. This is the drug we give that replaces dopamine in the brain. It's kind of like the key to therapy. So it's a big, big part of how we want to plan care for these patients. When they're in exacerbation, we also want to identify the reason they're in exacerbation. Do they have like a physical reason why they're exhausted? So things like an illness or excess activity, which has led to this depletion of dopamine in the brain? Have they had dietary changes that have led to bioavailability of dopamine? Or do they have medication tolerance? This isn't resistance to the drug. They're still getting all the drug into their brain, but their neurologic system becomes tolerant to the amount of drug they've been given. Kind of like people you know in college who develop a tolerance to drinking alcohol, so they have to drink a little more in order to experience the effect of being drunk. Same kind of thing can happen with levodopa. They're still getting all of that drug, they just need more of it in order to get the same therapeutic effect. And I imagine that is going to change the way you describe getting drunk for the rest of your lives. My gift to you for the day. So taking action, the things that we're going to do in nurse world on the chronic side, when patients are having chronic presentation of disease, ADLs with friends is our big thing. We want to call all the friends, all the interdisciplinary friends to see what help they can provide to this patient in order to maximize their independence. So when we talk about physical therapy, we're talking about interventions like mobility. So gross motor movements, how do they walk from here to there? When we talk about occupational therapy, we're really focusing on ADLs. This can be thought of as like fine motor movements, but anything necessary to complete their ADLs is really the world of occupational therapy. ST is speech therapy. So this is concerned with all things eating, drinking, and swallowing. Everything that happens in the mouth and neck is really the world of speech therapy. So making sure they can still maintain muscle control of their tongue and manage their secretions, manage fluid intake, big part of speech therapy. And then SW is social workers. Social workers are like the go-to person for management of Parkinson's disease, because they're the ones who can arrange for PT, OT speech therapy to see a patient. So we always want to work with social workers. Symptom management is also a big part. So part of symptom management is a medication schedule. Because levodopa is looking to replace or dopamine in the brain, it needs to be given at very regular intervals. So working with patients to set up a reliable medication strategy, medication timing is essential, because if patients are late by a few hours, that can lead to an exacerbation of all their symptoms. So we want to really prioritize taking their medication at the same time every day. Another part of symptom management is like bowel programs and bowel training. Loss of bowel control can absolutely be a part of Parkinson's disease. So we want to start patients on a bowel program. This is behaviors like going to the bathroom at the same time every day and kind of sitting on the toilet for 15 minutes at the same time every day, because that pattern will train the body that this is when we do this behavior. So at the same time every day, this is when we have a bowel movement. So that can be a big part of how patients can prevent incontinence as their disease progresses. And then psychosocial, this is a debilitating disease of elderly patients. So family support is a big part of it. So we always want to be assessing our patient and their family and making sure they have the support necessary to help manage this disease. For acute presentation, so an exacerbation of Parkinson's, we want to identify the cause. Is there an underlying illness, underlying exhaustion? Did they miss a dose of their medication? These are big parts of how patients can end up in an exacerbation of disease. Around medication, we want to really ask like the frequency of dosing and when the last time they took their medication, and assess for whether or not they're approaching that tolerance of medication. So is their dosing still appropriate? Or are they having symptoms despite taking their medication very routinely as prescribed? So for the evaluation side, independence for as long as possible is what we're trying to achieve with these patients. This is a chronic progressive disease, so they are going to lose independence over time, but we want to try and make sure that we're giving them as much independence for as long as possible. Injury prevention, also a big thing. Because of the musculoskeletal deficits associated with Parkinson's, they're at very high risk for injury. So we want to put interventions in place that'll help keep them from things like falling or hurting themselves, and also support their mobility by using tools like adaptive equipment. And then a solid medication plan. We want to make sure they can verbalize what their medication plan is, what time of day they can reliably take their medication, because that's the easiest way we can prevent exacerbation. So what we just talked about, don't forget that symptom recognition is a big part of the diagnosis of this disease. So we want to identify as many of those EPS symptoms as possible. Assessing and recognizing deficits in patients is a big part of how we set goals for their recovery, because we want to make sure that whatever kind of prescription we give them for how to manage their disease as an outpatient is realistic for them to carry out. Make sure we're meeting the patient where they are, not expecting them to adhere to an extraordinary solution to their illness. And then chronic versus acute presentation. If they're in an exacerbation of their Parkinson's, why? Always be assessing for that tolerance to their medication. EPS symptoms are always what we're on the lookout for. It's how we identify disease. So being very comfortable recognizing those symptoms is a big part of managing Parkinson's disease. And then managing this disease is always better with friends, help share the workload. So we want to get our friends like physical therapy and occupational therapy involved as quickly as possible.